In this section, we will review the different clinical manifestations of Coats disease. However, pediatric cases with massive exudative detachments will not be covered in this topic. First, let's review the types and classifications given in the last talk. In 2006, Ionuzzi proposed that the terms for retinal telangiectasia should be condensed into either retinal telangiectasia type 1 or type 2. Type 2 is known as macular telangiectasia, and that is discussed in another chapter. Type 1 can also be divided into two types, posterior or Coats. Posterior type 1 is just that. It involves only the macula, and we've talked about this in another chapter. Coats disease is another manifestation of type 1, but while it may be posterior, there will always be a mid-peripheral or peripheral component to the telangiectatic vessels. If you read some of the older literature, you may also see the term Leber's miliary aneurysms. In 1955, Rees suggested that this type, Leber's miliary aneurysm, is just a condition which lies on the spectrum of Coats disease. The clinical characteristics of Coats disease are mid-peripheral or peripheral telangiectasia associated possibly with exudation either in the fovea or in the macula. The characteristic fluorescein angiographic findings include peripheral capillary loss, dilatation of the residual capillaries in the areas of the capillary loss, and multiple aneurysms. Shields staged Coats as mild if there were only peripheral telangiectatic vessels, stage 2 or moderate if there were extrafoveal or foveal exudates, and then severe if the exudation was enough to cause an exudative detachment. Here is an example of stage 1 Coats disease. This is a 26-year-old female who was referred to me when the exudates were noted on a routine examination. Her vision was 20/20 in both eyes. Clinically, the macula is clear, there's no exudation, no telangiectatic vessels, and no aneurysms. In the periphery, you can see the hard exudates quite easily. Here is a composite angiogram of that patient. You can see the mild peripheral capillary loss, dilated capillaries in that area, and multiple aneurysms. The angiogram of the macula is totally normal. Now we'll move on to stage 2 or moderate Coats disease. And as you remember, this not only has peripheral pathology, but there are also telangiectatic vessels in the macula associated with macular or foveal exudates. Here is a 52-year-old male who's noticed a blur in the right eye for several months. The vision was found to be 20/70 in the right eye and 20/30 in the left eye. You can see the circinate hard exudates quite well, as well as some dilated capillaries and some aneurysms. Now, this is not a vein occlusion because the exudates are above as well as below the horizontal raphe. And here's the periphery of that same patient. You can see on the far right the circinate pattern of the macula, but you can see some obliterated veins as well as the white aneurysms in the periphery and a featureless look to the retina in the far periphery. There are not many exudates in this patient in the periphery. Here's the mid-phase angiogram of the macula of that patient. You can see the telangiectatic vessels and microaneurysms inferior, infratemporal, and temporal to the fovea. And here is a composite angiogram of this patient. You can see that the macular telangiectatic vessels are leaking, and the periphery shows large areas of capillary loss and a mild amount of leakage from the veins as well as from some aneurysms. Here's another example of a stage 2 that has the peripheral disease as well as macular exudation, but you'll notice that this patient is much more severe. At 6 months of age, there was a normal examination at Vanderbilt. At 6 years of age, there's a possible injury while playing football. The right eye was noted to have no vision and was found to be 3/200 on the full clinical evaluation. You can see a very abnormal red reflex. As a matter of fact, it's all yellow. You can see that the exudation is much more aggressive and much more widespread. This is generally the case in the pediatric cases. They're much more aggressive than those found in people who are in their 30s, 40s, and 50s. You can obviously see the very yellow exudates in the macula, but they are also in the superior and nasal mid-periphery. There's extensive peripheral capillary loss, almost for 360 degrees in this patient, with very dilated veins and telangiectatic vessels. We will revisit this patient in the talk on treatment, and you will see what happens to him in the long term. The last category of Coats disease that I'd like to cover has posterior and mid-peripheral large aneurysms. Labor first described these, but this condition is now considered to be on the spectrum of Coats disease, and it has lost the term Leber's miliary aneurysms. In my practice, however, there are some subtle differences in treatment between the first style of Coats that you've seen and this one with the larger posterior aneurysms. I'll show you an example of this, but then I'll go over to the treatment in a talk of its own. Here is an example of that classification. This is a 10-year-old, vision of 20/20 in both eyes, and some abnormal blood vessels were picked up on a routine visit. The things to notice on this composite are some aneurysms inferiorly and a reddish area along the infratemporal arcade, and I'll show a blow-up of this in just a minute. Here is the magnified photograph of that patient. You can see a number of aneurysms along the infratemporal artery. At this time, there's no visible exudation noted. The fluorescein angiogram shows the peripheral capillary loss with the dilated veins and some early aneurysms. The macular angiogram shows the aneurysms along the infratemporal arterial arcade, but there's also some leakage in the temporal macula, although that wasn't really seen clinically. So, in summary, Coats disease will all have peripheral telangiectasia, with or without posterior telangiectasia or exudates. They also may have larger mid-peripheral aneurysms with or without exudates. And also note that the Coats is much more aggressive in the pediatric age group. We'll be talking about the treatment of the different styles of Coats disease in the next talk. So for now, here are just short references for this chat. The article by Shields, even though it's back at 2001, has the most cases and is the most complex, and you can go from there. The references on Leber and Rees are there for historical purposes, and you can look those up as well if you wish.